Bueno, bienvenidos todos, a toda la gente que nos sigue por Zoom. Por favor, cierren su micrófono. Si tienen alguna pregunta, alguna duda, escríbanlo en el chat. Nosotros se lo hacemos llegar aquí al doctor Roberto. Igual a la gente que nos sigue por redes sociales, por YouTube y por Facebook, escriban y nosotros se lo hacemos llegar. Y bueno, Luis, te dejo para que presentes a Roberto. Gracias por estar con nosotros.
Bueno, tengo realmente el placer de presentar a Roberto. Roberto es una persona que yo creo que en cualquier momento que ustedes lo paren en cualquier congreso y le pregunten algo, Roberto les va a responder. ¿Sí? Así que no le tengan miedo de acercarse a Roberto. Entonces, el doctor Roberto Pineda, él es cirujano oftalmólogo, su especialista en córnea, enfermedades externas y cirugía refractiva. Es director del Fellowship del International Council of Ophthalmology, del ICO, y trabaja en Massachusetts Pioneer, y es director Global Surgery and Health en Massachusetts Pioneer. Por supuesto, es autor y coautor de numerosos artículos y libros que muchas veces los leemos también en el Injerto. Welcome and thank you so much for accepting our invitation.
Thank you, Luis. Es un placer para presentar esta tarde con una charla de Dwek. So I will give my presentation in English, but I want to talk to you today about a surgical procedure that we have been performing at our hospital since 2013. So for almost 7 years, as an alternative to endothelial keratoplasty for Fuchs. So these are my disclosures, which are not relevant to today's presentation. So, you know, we're all familiar with Fuchs. It has a very characteristic clinical feature with guttata that affect the center of the cornea and then slowly spread to the periphery. And you can see that here with the classic red reflex of the grouping of guttata. And then again, as the size and the number of the guttata increase as you move from the periphery to the center. And, you know, endothelial keratoplasty has really become the standard of care for patients with Fuchs endothelial dystrophy. And really, as endothelial keratoplasty has undergone a big change over the past 20 years, starting with Mellis discussing posterior lamellar keratoplasty back in 1999. And then with developments from Mark Terry and Mark Garovoy through DSEC, and then eventually DMEC by Mellis again in 2006. So most of us either perform DSEC or DMEC for endothelial, Fuchs endothelial dystrophy. And, you know, during this time, there was a lot of case reports about spontaneous remodeling of the corneal endothelial cells after Decimase stripping was performed. And, you know, these cases of clearing of the cornea after Decimase stripping occurred largely after cataract surgery, case reports, or after loss of DMEC grafts or DMEC grafts which scrolled. And a very popular paper is this paper by Shaw out of Emory, where they reported these cases of corneal clearing after Decimase stripping without endothelial replacement. So I want to talk to you a little bit today specifically about Dwek. Dwek is basically an abbreviation for desmetorrhexis without endothelial keratoplasty. Sometimes people refer to this procedure as DSO or Decimase stripping only. These are probably the two most popular abbreviations for this. But what's really interesting about this procedure, of course, is that this is not new. This was, for those of you who are not familiar with Dr. Pofiki was a French ophthalmologist who was very much involved, a cornea specialist, you know, in the mid-20th century. And he actually described stripping Descemet's membrane off in Fuchs patients and noticing that the cornea is cleared. And he wrote about this in a textbook from 1955 in Roycroft. So we're talking about a procedure that was performed over 70 years ago. And I think people kind of forgot about it. But really, it is the way to think about the Dwek procedures. That's really a regenerative form of medicine. So regenerative medicine has now become very popular, and Dwek, I think, represents a very very specific form of regenerative medicine for us in ophthalmology. What's great about this procedure is, you know, you're stripping off Descemet's, you're allowing the central peripheral endothelial cells to migrate or proliferate and restore the aqueous pump barrier so that the cornea clears, and you don't have to worry about rejection. Patients don't need to stay on long-term steroids. And most specifically, this procedure is really focused on for Fuchs endothelial corneal dystrophy only. It's not really for pseudophakic bullous keratopathy or other corneal endothelial conditions. Naming these procedures is always interesting, and this is a little editorial we wrote in 2018 about different names for this, but Dwek and DSO are the ones that have stuck. So in Dwek, as I mentioned before, you know, you have gutata centrally that basically reduce vision, cause corneal edema. And in the Dwek procedure, we're essentially stripping off a central area of Descemet's and the gutata, pathologic gutata, in about a roughly 4 to 5 millimeter zone. And then, you know, allowing those cells to migrate or proliferate and cover the central cornea again. So this is just a typical case of Dwek. So this is a woman that we saw. She was losing vision. This was earlier on in our case study, but she was actually amblyopic in that eye. Her vision was about best corrected to 2200. Her central corneal thickness was around 660 microns. She had a very confluent area of gutata centrally in that eye of about 4 millimeters. And you can see this area here and her specular down below. So we performed the Dwek procedure, and this is like a very typical kind of course we see with these patients. So obviously at week 1, you can see there's a little air bubble there, but the central cornea is very edematous, and you know, patients obviously don't have good vision. By 2 weeks, there's maybe a little bit of improvement, but oftentimes it looks very similar. You can see the OCT below. You know, vision the first and second week are count finger. But by 1 month, the cornea is starting to clear. And you can see the patient's vision here by 1 month is 20/125. And by 2 months has reached 20/70. And again, you can see the OCT below here corresponding to that area. And by 2 months, you know, you're able to detect endothelial cells on a specular microscopy. So this is, I would say, a very typical course, sometimes a little faster, sometimes a little slower, but this is what we see when we choose the right patients. So this patient, after 3 years post-operative, this is, again, early on, you can see this is the amblyopic eye that was 2200. Now the vision is 20/60 plus, and the CCT was like 668, now it's 593. Cell count is over 1200. And for the other eye, which was, you know, the better seen eye, the patient eventually decided to undergo surgery in that eye, and now is 20/20 with the cell count, central corneal thickness of 630 and cell count, again, of around 1200 microns, 1200 cells per millimeter squared. So again, you know, Dwek is really very good for the right early Fuchs patient. These are usually patients with mild to moderate Fuchs, and with good peripheral cell count. So I think this part is very important to understand. We've all seen Fuchs patients who have kind of limbus to limbus guttata, or where the guttata are quite extensive. And in those patients, these are not the patients we want to be doing this procedure on. It's really patients that have guttata confined to the central cornea with good peripheral cell count. You can see the specular microscopy here on this example below, where the central cornea has kind of confluent guttata, but the peripheral cornea actually has a pretty good cell count of around 1,800 cells per millimeter squared. And in this case, a month later, you can actually see improvement quite a bit in this patient's cornea, as well as they can already measure specular microscopy. So this is a little bit faster than average, but these are the kind of patients that you want to try to identify. The problem with the Dwek concept is that although it has the potential to heal after Descemet is removed, there is a large variability among patients. So some patients heal very quickly, other patients heal very slowly, and really this is where regenerative medicine comes into play, and we have to be able to try to understand a little bit better about the regenerative potential of the cornea and who might be a better candidate for this procedure compared to another patient. Now, clinically, a paper out of our institution run by Dr. Colby looked at a group of about 15 or so Dwek patients, and we were able to break these patients down into kind of 4 categories. Those patients that responded very quickly, those that were considered responders, and then those that were slower responders. Those were usually people beyond 3 months, and then those are the non-responders. So this was a kind of important concept because we do see some patients really within 2 or 3 weeks who are clearing very, very rapidly, whereas some other patients take 6 months or more to clear. So obviously, if someone's going to clear in 2 or 3 weeks, that might be a really good procedure for them. But if they knew it was going to take more than 6 months, they may choose not to do this procedure and have a standard endothelial keratoplasty. So I want to talk a little bit about factors that are involved in cell regrowth. These include things like cell migration and proliferation, cell to guttata interaction, and kind of the concept of corneal endothelial stem cells, which I think these are all relatively novel areas, at least clinically, for us as clinicians and surgeons, to talk about this in terms of Dwek and Fuchs endothelial dystrophy. So, what happens when endothelial cell encounters a guttata? Well, you typically see 3 different patterns. You see in pattern 1, there's normal growth of the cells and they form a normal sheath. These are when the guttata are very small. But as the guttata get larger, they start to form rosettes, but the cytoplasm completely covers the guttata. And then in pattern 3, we have much larger guttata. There's again the rosette formation, but in this case, the guttata cannot be covered by the endothelium. And I'm sorry, the endothelium cannot cover the guttata. And when that happens, this is just a ex vivo Fuchs endothelial cell specimen. When that happens, you basically see apoptosis. So when the endothelial cells can no longer cover the guttata, they become apoptotic. And that's been shown. You You can see the tunnel assay here with gutata versus non-gutata being statistically significant. The other area is really about looking for the presence or existence of neural crest-derived progenitor cells in normal and Fuchs endothelial dystrophy corneal endothelium. And again, this is a relatively novel area, but in order to understand regenerative medicine, we have to understand there has to be a progenitor cell or stem cell which can replace the cells that have been damaged. And these are just tissue cultures. This is from my colleague, Ula Yarkunis, who does a lot of work in Fuchs and endothelium in general. And you can see some cells form more fibroblastic patterns in cell culture, and other ones retain their more endothelial cell configurations. And after several days, this is day 17, you know, but as time goes on, you start to really develop two distinct cell populations or different cell populations. And those that are kind of more primary Fuchs cells and those that are highly proliferative colony-forming cells. And this is important because within that high colony-forming cells, you can start to identify different markers that are highly suggestive of a kind of a progenitor cell nature. And these are just research that they've done in their labs showing that there is actually these cells within the both normal corneal endothelium as well as the Fuchs endothelial dystrophy. And they're continuing to do work to try to isolate, you know, where these cells are in the, and how to identify them in these Fuchs patients as well as normal corneal endothelium. So the other question that comes up, other than stem cells, is what's happening here? Is this just endothelial cells sliding around, filling in the gap that we create when we strip decimase and the gutata, or are we actually getting some proliferation? Now, I think most of us who have been doing this for a while, who have access to confocal microscopy, we can demonstrate that some of these endothelial cells demonstrate bilobe nuclei, hyperchromatic nuclei, segmenting cytoplasm, things that are very indicative of mitotic activity. So it does seem that some of the endothelial cells, and which ones, which subtypes are difficult to characterize, but they do seem to have some mitotic activity. However, we have also demonstrated that the endothelial cell count in the periphery typically decreases, indicating a more migratory function of the remaining endothelial cells. Some studies haven't shown a significant decrease, other studies have. So I think the exact percentage of cells that are migrating as well as mitotic activity, you know, has yet to be better quantified. But I think both of these mechanisms are at play when we're performing the Dwek procedure. So let's talk about the procedure itself. So I think there's several steps to the procedure that we can talk about here. It's a relatively simple procedure. I think selecting the right patient is not so simple, but basically what we do is we want to mark the area where we performed the desmetorrhexis first, then go ahead and make an incision, inject some viscoelastic into the anterior chamber, start the tear with decimase, then go ahead and we'll talk about removal of decimase, and then and we'll kind of go over some of these different aspects. So marking is important. We care about centration and we care about the diameter. So, you know, it's very important to measure this out. It's not something I would just try to guess on. Sometimes patients have eccentric pupils. It's important to note that in the clinic exam. And, you know, also the size of the pupil in both mesopic and scotopic situations, because if you don't make the descemetral rexus large enough or you make it too small, the patient's going to be very symptomatic still. But in general, our experience and those of others have shown a descemetral rexus between 4 to 4.5 millimeters basically allows for a reasonable amount of gutata without creating too long a time between recovery. So some of the early studies that were done made 8 millimeter diameter removal, 6 millimeter diameter removal. In all of these patients, there was a much higher percentage of failure to clear the cornea. So this is just a marker that I have with the Seco. It's a 4 millimeter marker. It has some hatch marks on it, and I'll show some videos later with that. And there's a little crosshair there to help with centration. Making the incision, obviously, you can do this in conjunction with cataract surgery. So many of our patients are having cataract surgery at the same time as this procedure. If you're not doing cataract surgery, you can do it as you can do it through basically a paracentesis if you're using an MST type device. We typically use a cohesive viscoelastic in these patients. Let's see. You know, basically, if occasionally we have phakic patients that we're using, so it's not something you could do it also with an anterior chamber maintainer, but for phakic patients, I like to use viscoelastic. It gives me a little more flexibility. I think one of the most difficult steps that people have when they start this procedure is initiating the tear and decimase. Now, we have a lot of experience with DSEC and DMAC where we have to remove decimase membrane, but we tend to score that membrane. That means we're kind of cutting in to through the decimase and into the posterior stroma. The problem is when you do that, you tend to activate different cytokines that result in kind of metaplasia of the keratocytes, and that typically results in a lot of scarring and fibrosis because there's activation of TGF-beta. So in these cases, what you really want to do is just barely break through decimase and then initiate the tear kind of by gently pushing on the membrane. And you'll see that in the videos I'll show. And you want to basically peel or strip away decimase as opposed to score it with a reverse Sinskey like we typically do, because that induces a lot more scarring. And when it's at the 4 millimeter optical zone, it creates a lot of visual disturbances for the patients. This is just showing a very nice stripped, I think it was in one of the earlier slides, where you peel or strip the decimase. You get a nice clean line. And again, sometimes we use a curved reverse Sinskey to start, but you really just want to switch to some type of forceps to strip as opposed to score to prevent this scarring. I can't emphasize this enough, because I'll show you some pictures later about what can happen when that's not done. So again, it's not really that difficult in Fuchs in particular to remove decimase. For those of you who have done endothelial keratoplasty, we know the decimase comes off very easily, but it tends to break and tear. It's much more delicate than the anterior capsule when we perform phacoemulsification. But you can tear large areas, but it usually breaks, and you usually have to re-grab several times in order to complete the desmetorrhexis. I have a forceps that I use that actually is a small tooth on it that we use to start. It's 50 micron tipped tooth that we use to break through decimates, and then I grab it and perform a desmetorrhexis, and it works quite well. This paper here that we published a few years ago basically talked about the predictive factors for clearance after Dwek. And basically, this paper showed that when we stripped or peeled Descemet's membrane, we had a much higher success rate with the procedure than when we scored. And I think this paper highlighted the importance of surgical technique in making the Dwek procedure successful. And most people who perform this procedure now use a stripping or peeling procedure as opposed to a scoring procedure. Let's see. So again, just some key points about the procedure itself. We tend to limit the size of the desmetorrhexis, aiming for about 4 to 4.5 millimeter desmetorrhexis. Again, centration is very important. If the desmetorrhexis is decentered or not centered over the pupil, the transition between the desmetorrhexis and the residual decimates is going to create a lot of optical problems for the patient. It's also important not to leave any tags because those will scar centrally and create a lot of glare.
Bueno, ahora que me acordé.
See, I'm hearing someone speaking. Okay. So again, okay. The other point is, again, stripping and not scoring. And we don't want to damage the stroma at all, because that'll basically inhibit the endothelial cell migration and affect the outcome. So this is just one of the initial surgeries we performed with this procedure. You can see I'm using a reverse Sinski. This is very early on, but it's good to show everything. You see we start the score. Here I'm using just a pair of Utrata forceps. This is before I developed any of these other instruments. It's a little bit harder, but you can see we can grab the tissue and just very carefully perform this. Again, it's much thinner than the capsule rhexis, and it tears very easily, and you have to re-grab it several times. And then sometimes you have to reverse direction as well. And you can see I'm kind of starting again. And it's a challenge. I'm using the reverse Sinski again to just tear the edge of this Decemate membrane, re-grabbing again. Again, the angle is very hard with these Utrata forceps. There's a reverse pair of like Utrata forceps that potentially would work very well for this. Also, the forceps require a slightly larger incision. This is probably a combined phaco wound. And then we go ahead and remove it. So with this next video basically shows with the marking with the new instruments, you'll see this first one I really didn't mark. And you can see it's very hard to center. But when you mark things, it's a little bit easier. Again, there's different ways you can do this. Those hatch marks are nice because you can see in between them. This is this tooth forceps, so you can start the rhexis here, and once it's started, you can then grab it with the forceps and tear it. And again, these Decemate membranes are much more fragile than the anterior capsule, and many times we have to switch direction, but usually it peels off very easily. And if you have to go very slow because you can't control the size of this as easily as you can a capsule rhexis. But this very, very smooth edge is critical to making sure patients don't have a lot of visual symptoms afterwards. Here you can see this little tag I was talking about. You don't want to leave any of those tags there. They will scar and create severe optical aberrations for the patient. This is the last one. I think it also uses the marker again. It's sped up just for time. And again, I think this was the patient already had cataract surgery, and their Fuchs had gotten worse after surgery after several years, and we're just removing the Descemes again in these patients. Obviously, having a good visualization is important. Having a red reflex makes it much easier. So when you're doing phakic Dwek, I don't put pilocarpine in, but I don't dilate the patient either. And sometimes that can be a challenge because the red reflex is not as good and it's not as easy to perform the procedure. But this round, smooth edge, it's critical for cell migration and also for visual symptoms, or minimizing visual symptoms. So, I mean, you can see the procedure doesn't take that long and is relatively straightforward to perform. But really picking the right patient is really what's the challenge. You know, at this point, and then we just remove the viscoelastic as we are here. So those are just some videos demonstrating the procedure itself. Obviously, all surgical procedures have complications. Probably some of the biggest ones we deal with is when things don't recover as quickly as we like. There's delayed healing, there's chronic edema. I've had one patient who was very slow in recovering. He developed some subepithelial bulla, and the bulla ruptured and actually became infected, and he developed a bacterial ulcer or keratitis. And obviously the edema affects vision. Centration of the rexus, as I mentioned, is a big deal. And this stromal edema and scarring can also be a problem depending on how the Descemes is removed. You can develop these posterior nodules from the scraping technique, and you can see that here, this courtesy of Greg Maloney, who's done a lot of work in this area. You can see these nodules here on slit lamp exam, and they are very visually significant for patients. Patients can see 20/20 and they'll have terrible glare. So the posterior cornea, we think the anterior cornea is very important for people's quality of vision, but so is the posterior cornea. The other thing, if you're performing this procedure with in a patient who has, you're also doing cataract surgery on, there's a hyperopic shift, very similar to what we see in DMEC. And we reviewed our cases of Dwek combined with cataract surgery, and we found out of 25 eyes, there was a hyperopic shift of about 0.38 diopters from our target. So we always adjust our IOL calculations for a half a diopter hyperopic shift when we're performing this as a Dwek triple or combined procedure. Also, we've had a few cases where we've actually performed Dwek surgery and then the patient in a phakic patient, and then they've later gone on to develop cataracts and need cataract surgery. So this is also an interesting situation. Unlike most Fuchs patients where we worry about the cornea decompensating after the procedure, these patients have all stayed clear. And what's really interesting is their endothelial cell count actually increased. In this case, case report we put out a few years ago, the cell count went from 1471 to 2373. It increased like by 800 cells per millimeter squared on multiple visits. So this seems to be quite safe to be able to perform phacoemulsification after the procedure. This is just a table, kind of a compilation of clinical outcomes after Dwek in series that had included more than 3 cases. And you can see in general, most patients had a very good visual improvement anywhere from better than 20/20 to 20/40 in most cases. Some patients, I would say what's not included here is the failure rate. So in general, I would say that Dwek has about a 80% success rate in the literature. So that means that 20% of people, need to go on to have an endothelial keratoplasty after the surgery. In general, most of these patients can get measurable endothelial cell density counts by 3 months after the procedure. And these tend to slowly increase over the course of the first year after the procedure. Not everyone thinks this is a good idea. There's been several papers which have looked at, these were earlier on, that looked at Dwek and just really felt like the prolonged edema and some of the symptoms were much less desirable, and the less desirable post-operative course was not good compared to the rapid clearing that one got with, let's say, DMEC surgery. But what I found is that our patients are actually, are able to make a very good, well-informed decision about whether they want an endothelial keratoplasty or whether they want to try Dwek. I tell patients the benefit is they don't need to stay on steroids for life. Most of our patients maybe stop steroids as early as 3 months after the procedure. Some patients are on it for a year, but rarely after a year is anyone taking steroid drops. We don't ever have to worry about rejection. DSEC has a rejection rate of around maybe 12%, 10 to 12%. DMEC has a rejection rate of 1 to 2%. And Dwek has a rejection rate of 0. So we do have a failure rate where people don't have successful clearing, but all my patients who have cleared over the course of now more than 5 years, none of them have gone on to fail. Now, again, this is a new procedure, and it may be in another 5 years, half of them will have failed. But I've been impressed that my patients have remained clear over a 5-year period. Yes, so this is another paper kind of debulking it. There's a nice paper by Dipender Dhaliwal out of Pittsburgh that compared Dwek to DMEC for Fuchs. And this paper came out in Cornea in 2018. And basically what they found is that basically, of course, DMEC was quicker in achieving 20/40 vision. It took about only 2.5 weeks or so for patients to achieve 20/40 or better vision with DMEC. Well, it took 7 to 8 weeks for that for Dwek. But there were a lot of adverse events for the DMEC patients, people needing to be rebubbled, IOP issues, etc. in half of the patients that had DMEC, where the patients who had Dwek, the adverse events were 0. So in many ways, Dwek is a safer procedure than some of the endothelial keratoplasty procedures, such as DMEC. And I think that their conclusion was that DMEC and Dwek have very similar outcomes, but Dwek has fewer adverse events compared to DMEC. So this is what I was just saying here. So that's why this is, I think, a very, and then of course, we have to look toward the future. And we talked a little bit about regenerative medicine, but cell therapy is the next area that's going to be a focus. And this is a paper that was published by Dr. Kinoshita in 2018 in the New England Journal of Medicine, talking about the use of cultured cells with a ROCK inhibitor for bullous keratopathy. And basically here what they're doing is taking healthy endothelial cells from very young donors, culturing them, and then essentially injecting them, going in, removing not decimase, but just the endothelial cells from the cornea. Then injecting these new cultured endothelial cells into the anterior chamber, and then having the patient lie flat for face down. So now we're like retina surgeons, face down, and they stay there for 3 hours. And this included some patients with Fuchs, some patients with bullous keratopathy, and this is their 11 patients, and all 11 patients cleared with this cell therapy. And this is 2 years after cell injection. They've now performed 65 cases, and I think that for patients that maybe Fuchs patients who have limbus to limbus cuttata, who are not good Dwek patients, this might be the next kind of therapy that we might offer those patients. So this is the future, regenerative medicine, cell therapy for endothelial corneal disease. I think we're going to be hearing more about this in the future. You know, again, I mentioned our experience started actually with Dr. Colby performing the first case in 2013. Dr. Kunis and myself started in 2015. We've probably done, I mean, together, I'm sure we've exceeded maybe 70 or 80 cases at this point. And, you know, most of our patients have done very well. I think I've done maybe close to 50 cases at this point, and I've only had 2 patients that I've needed to perform endothelial keratoplasty on because they did not clear. I did have 2 patients who did take more than a year to clear, but they were very motivated. In general, like I mentioned before, most patients have cell counts by 2 or 3 months, and by 6 months, they typically have cell counts between 500 and 1,000 cells per millimeter squared. And typically, all our patients are usually off steroids after 1 year. And I didn't talk a lot about the use of ROCK inhibitors, but we are now using ROCK inhibitors with our Dwek procedures, either using Repository, which is Glanatec, which is available in Japan as a glaucoma medication, or the Nertoserdil, which is the new glaucoma medication, which is approved in the US. We've actually found that the Repository is maybe a little more effective and has less side effects than the Nertoserdil. But we are including that, which the patients take. The dosing is a little unclear, but usually around 4 times a day for the first month until they start to clear. Once they start to clear, we usually reduce the ROCK inhibitors. The ROCK inhibitors themselves are felt to improve cell migration and cell proliferation. So they're adjunct therapy, which we think is helpful. Our first paper from the Dwek patients actually did not include the use of Nertoserdil, and all of our patients cleared in that first study. So you don't need a ROCK inhibitor per se for this procedure, but we feel it will help accelerate visual recovery. And there's several ongoing studies right now looking at the use of ROCK inhibitors with the Dwek procedure. So in summary, Dwek is a new form of regenerative medicine used for treating early to mild Fuchs endothelial corneal dystrophy with healthy peripheral endothelium. The challenges, as I mentioned before, the recovery rate is very variable. We think surgical technique is very important to achieving good vision, as is centration and stripping or peeling as opposed to scoring for good visual outcomes. So again, the role of ROCK inhibitors I already mentioned, I think is important. The role of intraocular pressure is another area which I've explored a little bit. I had 2 patients who were not recovering after Dwek surgery. Their pressures were around 21 millimeters of mercury. I placed them on other additional glaucoma medications and brought their pressure down to like 15, 14, and within weeks their corneas cleared and their cell counts increased. So I believe intraocular pressure plays a very important role in facilitating cell migration, and I make sure all my patients have lower intraocular pressures in the postoperative period to try to facilitate recovery, although I don't have any publications, and there are no publications on this particular topic. So thank you very much for allowing me to share my experience with this procedure, and happy to answer any questions.
Dr. Pineda, thank you very much for your great talk. It was amazing. I think that is a very interesting topic. There are some questions right here in the audience.
Of course.
Dr. Fiorella Casanova, she's asking, what is the minimum peripheral endothelial cell count that you consider to perform the procedure? Do you perform any different specular microscope, or?
So we have the NIDEC specular microscope, and we have a confocal. But the NIDEC gives you can give you a more peripheral measurement to give you an endothelial cell count. I think we like cell counts. Basically, I don't think there's a strict number, but I would say you want a peripheral cell count of probably more than 1,600. And you want to look at cell morphology as well. So yeah. I think the number as well as the morphologic appearance would be important.
Excellent. There are more right here. What happens if, okay, you do the Dwek and doesn't work? What's the next step? 3 months later, probably there's going to be some fibrotic tissue or so.
So it's very rare that people don't completely, they improve somewhat, but it's possible that, basically what we tell patients when we consent them for the procedure is that if they are not showing improvement by 3 months or any improvement, we tend to recommend endothelial keratoplasty, and they can decide even sooner. But most patients do show signs of progressive improvement. If they stop improving, that's usually when we offer them endothelial keratoplasty as an option. But they understand from the beginning that there are fast responders and slow responders, and unfortunately non-responders who may require endothelial keratoplasty. But that's part of the consent process that I think is very important. And as we better understand who the better candidates are for this procedure, hopefully that percentage will go down. I mean, personally, in my own experience, I would say I have a 95% success rate. So, it's very rare, but I think you have to pick the right patients that truly have, very central gutata with good, healthy peripheral appearing endothelium. And I think a good exam with a good red reflex can easily show you the distribution of guttata, whether they're confluent or scattered, and you know, how much the peripheral cornea is affected.
Great. How patient you gotta be when you are checking these patients daily, or I mean, I don't know, weekly, and just to see, okay, definitely this guy is not going to improve at all, or I mean, what are your parameters that you think that probably can tell us?
Right. So we don't expect any real visual improvement in the first 2 weeks. We typically see the patient like we would a corneal transplant patient or an endothelial keratoplasty patient. So we're seeing them the day after, a week after, maybe 2 weeks later. And then usually at a month, we normally would start to see some improvement. You can usually see the corneal edema starting to improve. The patient can usually tell you that their vision's starting to improve. And for most people, it's between the 1 and 2 month period that they really see the biggest change in vision. So, I mean, we are getting ultrasonic pachymetry. You know, we are checking visual acuity. We are checking intraocular pressure, as I mentioned. If people's eye pressure is elevated, we work very hard to reduce the pressure to help facilitate recovery. In the beginning, we also place the patient sometimes on 5% sodium chloride drops or ointment at night to you know, facilitate deturgescence of the cornea.
Perfect. When you're talking about endothelial surgery after a failure in the Dwek, so you mean DMEC or DSEC? Which one do you prefer?
Well, it kind of depends on the situation. So obviously, patients that have a normal anterior chamber, you know, I think DMEC is fine. If the patient's had a vitrectomy or doesn't have an intact capsule, you know, then I would be doing a DSEC. So it kind of depends what the clinical setting is. I mean, my preference is to do DMEC if it's possible, but you know, some of the clinical scenarios don't make for a good DMEC candidate.
So the incidence of rebubbling is the same as the normal DMEC, or there is any increment in rebubbling?
You know, so sometimes, you know, it's interesting if you sometimes place a small bubble in the anterior chamber, and it's basically to minimize the corneal edema. So it's just to minimize the amount of edema the patient has initially, but it's not necessary. In the beginning, we didn't put any bubble at all. So okay. Bubbling is not required.
Good. The ROCK inhibitors that you are using, you use them for a certain time? I mean, the first 6 months, I don't know.
So the ROCK inhibitors are just required usually in the first month or two until the patient start edema and starts to improve and their vision starts to improve. That usually tells us that the cells are migrating or proliferating at the normal pace. Studies have suggested it's probably more beneficial for the older patient as opposed to the younger patient undergoing Dwek surgery.
Roberto, one question.
Yes.
What about these 3 ones who needed a DMEC after that? The follow-up of them, the behavior of the DMEC was the same like a regular DMEC?
Yes, Luis. There's not really much. Sometimes if there's been some edema, that area can take a little longer to clear. It doesn't clear quite as quickly as it would if I just stripped it off in a Fuchs patient and put a new DMEC, but it sticks fine. It's a relative. So I've tried 2 things. One is you have to enlarge the decimate stripping. So that's one thing that you have to do. That's a little different because you have this area centrally that's not stripped. So you have to strip this kind of funny area, which can be centrally, which is a little, you have to just make sure that you remove all the decimase centrally. So that's the, I guess, challenge if you have to do an endothelial keratoplasty afterwards. I mean, you could, in theory, just put the graft up without stripping, but I usually strip a larger area other than the central 4 millimeter. I make the standard 8 millimeter strip for those patients.
You know, the other day, some of my fellows asked me about that, was some months ago, why just not wash endothelial cells around the 4 millimeters and without decimeter stripping? So tell me, why is not? Why you are not doing that?
Yes, so I think that is a possibility. I think we don't really have the tools to, you know, when you strip the decimase, it's very clean. We can see the margins very clearly. I think we don't really have the clinical tools to wash off just the endothelial cells alone. I mean, I think this new technique that Dr. Kinoshita has developed does use some kind of brush or something to remove the endothelium, but you don't, in that situation, you don't want to remove decimase. There's also Jod Mehta, you know, described basically doing the Dwek procedure, but then transplanting new decimase, like in the area that's stripped, because it seems like the decimase provides a better substrate for cell migration. So your point is, I think, very appropriate. I mean, you know, it's an important question. I can imagine in the future, maybe if we have a better way to define the removal of the endothelium or the guttata. The problem is the guttata. So I think, you know, the guttata are in basement membrane. Even if you washed away the endothelial cells, the guttata are still there, unless you remove decimase. So that's the problem I have with Dr. Kinoshita's technique, because his technique doesn't remove the decimase. So I'm not sure how you're removing these pathologic guttata, which I've showed earlier, affect cell apoptosis.
Exactly. And, you know, we tried twice, okay? Using the femtosecond, okay? We did like we tried like a capsulotomy of 4 millimeters. And so we moved the capsulotomy to the cornea, okay? For Dwek, I had just 2 cases because I tried just to be curious, okay? And was really nice because it was really well centered. You can center over the center of the pupil. Then the laser did under the first 1 to 200, okay, depth, and we make a circle of 4 millimeters. Perfect, okay? So basically, one of the eyes recovered in around 4 to 6 months and was fine, but you always find the circle. The other one not. So we did a DMEC on that area, but was really easy to strip after you cut with the femto. The only problem that I have is that maybe the scar. I don't know. So what do you think? Because it's something, you know.
Yeah, so Luis, I think that's a brilliant technique. My concern is just the energy that's used by the laser. I think it's enough to trigger release of cytokines of TGF-beta, and so you end up like, you know, when we do LASIK, you know, you can easily think about the appearance of the LASIK flap or LASIK flap edge with a femto cut. You can always see it versus a microkeratome, which is almost invisible. You can't see it, because there's you know, even though it cut through it, I don't think there's this energy that causes the same kind of release of cytokines that you get with actual laser energy.
Okay,
So
thank you.
I think something like this.
All right. Yes, we have to think about it. So
Yes, yes.
Well, Roberto, first of all, thank you so much. Muchas gracias, Roberto,
Fue un
por la
placer.
de verdad, esperamos tenerte próximamente.
Okay.
Ya, y decir un abrazo
Gracias.
a la distancia.
Okay. El próximo tiempo, ¿no?
Sí,
Mucho.
sí. Y en este momento nosotros tenemos la costumbre de abrir los micrófonos y agradecer normalmente a...
Gracias.
Gracias, Roberto.
Until next time, Luis.
Yes. Thank you. Big
Okay,
hug.
thank you. Thank you. Have a good evening, everyone.
Thank
It was a
you
great
for the
pleasure
next.
to have you already here with us. Thank you very much.
Thank you.
Chente, ¿qué es eso?
Aquí ando, y bueno, para recordarles que tenemos la próxima, bueno, el día de mañana va a estar con nosotros, un segundito, el doctor José Mura de Chile, va a estar con nosotros hablando de cirugía de catarata y glaucoma. No se lo vayan a perder, 5:30 de la tarde, misma hora. ¿Se escucha?
Sí, pero estamos viendo Star Wars. Ah, ya está.
No, yo tenía ahí la presentación desde hace rato. Listo. Muchísimas gracias a todos. Nos vemos el día de mañana.
Excelente. Gracias a todos.
Hasta luego. Chao.
Chao.